treatment, because the longer you wait, the less effective or the outcome is not as good. So, yes. Okay, presbycusis, natural aging of the auditory system. So that just happens over time. Those hair cells get a lot of use, and so with any system in our body, it's just natural aging. So, okay. All right, tinnitus, here's your slide, yes, okay. So tinnitus is just very mysterious because so many people have it, and we don't really have a solution for it. So it can be ringing, hissing, buzzing, humming, chirping, I mean, you name it. I've had people tell me they think that it sounds like a telephone pole, that buzz or hum, or just like they can get really descriptive of what it is because they live with it 24/7. And so they can tell me exactly what it is, what pitch, all of that. It's pretty crazy. They get descriptive. So causes, hearing loss, medications, stress, smoking, Meniere's, acoustic neuroma, which would be some sort of a tumor or growth on the auditory nerve, TMJ, so clenching of the jaw, sometimes folks will experience it, ototoxicity, etc., because there are so many things and sometimes we just have it. So one of the theories that one of the hearing aid manufacturers has discussed is that it's similar to that of phantom limb. So researchers down in Oregon have been really looking at this because we're like, it's this mystery in the field of audiology and hearing. It's like, what do we do with this? And otolaryngology, the ENTs. So basically, when servicemen and women come back over and they're missing a limb, they perceive pain. And our brain is sending out a message and wants an answer. So when there's a limb missing, there's no answer back. So the brain is creating this fictitious pain that is very real for them. And so what they're looking at is the cochlea or inner ear. When there's hearing loss, the message is sent. There's a lot of afferent messaging going on to the cochlea, and there isn't a message getting sent back. And that was those little hair cells that were all distorted. So the theory is that the brain is creating a sound because it doesn't have sound to process because there's damage in the cochlea. And that's why we get tinnitus. Because even folks who are completely deaf per se, they have no audible or no measurable hearing, perceive tinnitus. So it is at the level of the brain. It's not coming from the ear. So it's one of those things that we could research about it, and we will till the end, because a lot of folks they don't get relief. So a lot of the treatments, hearing aids, providing amplification, so giving the brain more sound to process. So all those soft, subtle sounds that a person may not be hearing, put the hearing aid on. It's a spectrum. Some folks find relief, some folks don't. It's really hard. There are hearing aids that have chimes. They sound like wind chimes playing in the background, and they're fractal tones, so they never repeat. So the brain is always kind of processing because it doesn't catch on to the rhythm. So, yeah, yes. So, and some people, when I say wind chimes, they're like, they don't like the sound of that, and they don't find that relaxing. They find it bothersome. And then other people get really into it. It's called Zen. And so it's this kind of, meditation, stress reduction. I'm like, I need some Zen. I was like, I'm going to program some up for myself, some hearing aids. So, yeah. So it's kind of interesting what's out there. All right. Diagnostics. I think we need a hearing test. Why the heck do I need a hearing test? So, yeah. I have to say that I hear some very comical stories, and at times I feel like I'm a marriage counselor, and I'm not qualified to be doing this. Let's go back to the basics, communication strategies, because it's really hard when your communication partner can't hear, or you can't hear them, and it's, the burden's on both. So it's one of those things that, yes, so it's kind of funny.
Yeah, I actually like it when my dad translates what he thinks we said, because it's absolutely hilarious, and then we get a good laugh over it.
Yeah.
No, you're right. It did sound, I can see where it could sound like that, but you're right, that's not what we said.
Yep. So, yep. Okay, do you guys want to take a quick little break or do you want to keep going?
You're fine.
Okay.
Roll on.
Okay, keep going. Okay.
Yeah, you're doing great. Thank
All right, so let's start with the basics as far as diagnostics go. So when a patient comes in, so otoscopy is so simple yet so important because we have to look into the ear to be able to do any testing and have a clear ear canal. So we're looking for some landmarks. You can see there's this little cone of light. Sometimes we can see portions of those ossicles. If someone has a fairly thin eardrum, we'll be able to kind of see through and see a little bit. Sometimes when folks will have an ear infection going or something, or there's fluid, you can see little bubbles in there. So it's kind of interesting to see. Down here, this is a tube. So that's typically what they look like. There's a couple different styles. There's some that protrude really long into the canal because sometimes an ear will reject that tube and it'll either come out or it'll go in or yes. So, yes.
Using an otoscope and looking inside the ear, one of the things that when I'm looking inside, you have you're looking at the drum, and occasionally you'll see how it's like a pearl color, but sometimes you'll see it's white. It might be very white in places or have lines of white and stuff. What is that I'm looking at when I see it?
Yeah, so sometimes it can be scar tissue. So sometimes I'll see kind of portions where someone's like, oh yeah, you know, when I was such an age, my eardrum burst, and so when it heals back together in certain places, it can be kind of that streaking that you're talking about.
Yeah.
Sometimes when I see a white eardrum, or it's like very white looking and chalky and almost kind of a twinge of yellow,
Yeah.
I'll usually refer because sometimes that's an infection going on. So, but then on the other hand, sometimes I have patients and that's just the color of their eardrum. So it's hard to say, but I had one patient who had I was looking at his ear and I was like, gosh, that just doesn't quite look right. I had that gut feeling of, that's not quite right. It was kind of that, it was very white, chalky, and had a twinge of yellowish, and I'm just going, that doesn't look quite right. So I sent him over to our ENTs, and he came back in a couple days, or a little while later, because he's one of my hearing aid patients, and he was like, oh my gosh. He goes, you sent me over there. I had this horrible infection in my ear, and it was actually draining through the eustachian tube down into the back of his throat, and he had gone into the ENT for, he kept going back in going, something's wrong with my throat, something's wrong with my throat. It was that infection draining down through there. So he was like, I've been taking all these allergy pills and all of this and all that, and he was like, thank you. So it can be something as simple as that. It's kind of just seeing it and going, you know, that doesn't quite look right. And that oftentimes is a sign of some infection or something going on. We see that very opaque eardrum.
Yeah, and sometimes when you see it, sometimes it looks like a road map kind of thing, and sometimes it looks like you know, those rocks when they grow, or you know, how it kind of goes like. Which I can explain it. It's like a pattern.
Yeah. Okay.
And I've always wondered exactly what it was I was looking at when I saw that sort of thing.
Yeah, and sometimes it's actually, I don't know if this would sound about right or not, but sometimes it's just the ossicles. And there are two nerves that run through the middle ear space. So for people that have a fairly thin eardrum, you're going to see some marks because you'll see those bones that are, because they're connected to the eardrum. And then also there's two nerves. Rarely do I really see those. It's more of just the ossicles, I would say. But yeah. So yes, another thing, earwax. I do earwax removal. I'm like, it's one of my favorite things to do. I know that's weird, but I love it. It's like so satisfying. It's like, let me clean that ear. I love it.
You just don't like blood removal.
Yeah.
Really huge blood flying out.
Oh, and the patient's like, oh, it feels so much better. It's like, oh, it's just so satisfying. That I would be like, I'm getting in there. So I've got a pen light with a little curette on it, and so it turns on, and so I can see what I'm doing. It's light, and then it's just like this little loop here. So I just go down, scoop it right out, and we don't get to play with the big tools, the suction. I wish we did. So we have to send them next door to do that. So,
Why
And you
not?
just get to clean them out.
yeah, you
Really
guys.
just play with them.
Right, yeah. So that's my love of earwax. There we go. Okay, so how many of you do otoscopy in your job? Okay, so one thing, my aunt and my cousin, they're both nurses, and I bring my otoscope to family functions because I do a big
right
ear
on.
cleaning. So just in my spare time, another hot crabbing weekend, I bring my And the one time I didn't bring my supplies, my uncle was like, Jessica, are you gonna have your clinic open? And I was like, oh, Uncle Jim, I'm so sorry. I didn't bring this stuff. I was like, don't worry, I'll bring it to Christmas. And he's like, okay. So, yeah. So it becomes pretty popular with the family. All right. So, yes.
I'm sorry, don't mean to interrupt.
No?
So, I'd say about a third to almost half of our patients come in with quite a bit of, earwax and stuff. And what I've been telling them to clean, how to clean their ears. We don't do the ear cleaning at our clinic for them. So I tell them never use a Q-tip. And I also tell them that the inexpensive, easy way to clean is get one of those like red rubber paste bowls you find in the pharmacy, fill it with a 50-50 solution of warm water and hydrogen peroxide, and just forcibly flush it out over a sink until you quit seeing that stuff come out, and then do the other side and dry the ears. What do you guys do in your clinic?
So that kind of the lavage type flushing. So I worked with one audiologist, or I did some training with her, and she did the same method, but she actually used a squirt bottle with a little hose on it and with warm water. And so we just had a little pan here, and then we just sit there and squeeze until it came out.
I've done that too, also.
Yeah.
But for a person by themselves,
right, to be able to do that. So yes, I don't think that's harmful. Oftentimes using, I would say, just water though. The ear is pretty sensitive to pH. It's acid, it's acidic. And so that's one thing to take into account, is that sometimes it can cause, like skin type irritations and things like that. So maybe just warm water, I would say. But that's, people flush their ears pretty often. Of course, preferably, sometimes primary care physicians will clean it, because really you can just kind of see what you're doing. Sometimes water will get trapped in there, and then it puffs up the wax, and then we get an infection going. So it's hard to say. It's, one of those things. But
you get some people who have ears that look just clean as a whistle, and other people, it's impacted.
And it's hard, and it's dry, and it's super painful to remove. So.
Yeah, so my son has a lot of wax buildup. He's pretty grown up now, but our family doctor told me to have him put his head down, drop a couple of drops of peroxide in, let that sit, flip them over, and it all drains right out.
Oh.
And it is peroxide, straight
that was-
peroxide, and it kind of bubbles and tingles, and it really. But now it makes me nervous when you say
No,
that.
I don't think it's so bad. I mean, if you've been doing it for a long time, it's been successful for you. And honestly, I'm not a medical physician. I'm an audiologist. So if your medical physician said that, then that's great. And it worked. It sounds like it worked great for you. So that's fantastic.
Because he gets really bad.
Yeah.
He's coming home for spring break, and I have to clean his ears.
I have to
Clean my ears off. Yes. All those little things that you try to get done when you're home on break. Can I get an ear clean? Yeah. Okay, so with otoscopy, a lot of times I see this. Someone just comes at you, and it's like, ooh. Especially with kids, they move, they're all over the place. It's like you want to brace. So when you hold it, it's like this. So here's my otoscope, and I'm going in like this, and I've got my finger rested against their face, so that if they jolt or move, I'm not jamming that specular tip down into the ear. So often I see that people are not bracing, and it's so incredibly important. I mean, even adults will sometimes, if their ear tickles or something, they just jolt, and it's like, they're like, oh my gosh, I'm so sorry. And so, the span, it's good to brace. Yes?
This may sound a little mean, but the technique I use is when I examine the ears, I tell them, I'm going to yank back and up.
Oh,
yeah. Oh, yeah?
No, seriously, and I grab a good hold of that ear, and They're more concerned about that than anything else that I'm sticking.
Right?
Yeah.
Yeah, no, absolutely, that's in back, so you just gotta get in there and really,
Yeah, you have to be able to.
yeah, the canal has 2 bends.
I
So,
don't say up and back, I say I'm gonna yank it up and back.
I like it, it's honest, it's real, yeah, that's good. Yeah, no.
And then I,
Yank your ear, that's good. Has anyone said no?
Not to me.
My earring just fell out. Don't get this on video, my earring just fell out, Anthony.
Oh, it's too late.
Okay, so yes, so bracing. Okay, otoscopy. Okay, so evaluating hearing test. Raise your hand when you hear the beep. We have some different pictures across the lifespan here. So our little baby isn't raising their hand. This little girl probably may not quite understand that instruction yet, but obviously this woman and the lady over here, they can do those instructions. So now I'll kind of talk about some different tests that we can do across the age span. Okay. I love cats, so I just have to throw a little kitten in there for you. All right. So objective measures where the person does not have to respond, okay? Objective versus subjective. Objective, I sit, I don't move, we're measuring a response. Subjective, I'm raising my hand because I'm hearing the beep, okay? So tympanometry, that checks the movement of the eardrum. So we do a lot of that on little kids when they're coming in. We want to recheck hearing or things like that to see if there's fluid in the ear. We'll do tympanometry. Otoacoustic emissions, that's what this is here, this little baby. So essentially with that, if someone has normal hearing, when you present a sound, there is a response that can be measured from the ear, and it's from those hair cells in the cochlea or inner ear. So every baby, there's newborn infant hearing screening, every baby has otoacoustic emission testing done. They do one test, I'm so out of the pediatrics, and then I think they do another follow-up, and then if both times they don't pass, they'll have them come back for the automated brainstem response, and that's where they scrub some little electrode spots and they present sounds and measure the brainwave response. So that's kind of a more thorough type test to really ensure that if the child does or does not have hearing loss. I got to work in a rotation down at UW Med Center for all the little NICU babies, and it was like the sweetest thing, and we had to do ABRs on them, and so you have these little teeny babies, and I'm sitting there with this little like sandpaper cream buffing spots on their head and their ears, and I was just like, oh my god, I feel terrible. But you know, it's important to find out right off the get-go what the status of your child's hearing is.
And he's still smiling.
Yeah, he's loving
That was
this
long.
sound.
or something.
Okay, so subjective measures. So the hearing test, the audiogram, we're testing across pitch and volume, or the decibel measurement. And so low bass tone, mid out to high, very soft sounds, getting louder. This illustration has different little pictures of how loud sounds are and at what pitch, so it's kind of that graph. So we test through air conduction, so that would be the whole auditory system, outer, middle, inner ear up to the brain. We also test bone conduction. So if you remember back to that slide with that little kid that didn't have the ears, the anosha, we can place a headband on and it presents sound through vibration. We're bypassing the outer ear, the middle ear, and going directly to the inner ear. So we hear in 2 ways, through acoustic sound waves and then also through vibration. Another portion we do is speech testing. So as far as speech recognition goes, we're trying to match the softest level one hears tones with the softest level that they hear words. So we average out a couple of frequencies here, and then I say words like baseball, cowboy, airplane, downtown, sidewalk, all these words getting softer, and we want that soft level to match those tones, the average that we hear with these tones. So it's just a check. So a lot of fakers. We get a lot of, it's this age, a 7-year-old little girl. They love to fake hearing loss. It's like the strangest thing, but very common. So also if they have a younger sibling and they're wanting attention, things like that, we just see a lot of young girls come in, and so I'll have the tones cranked up, and I mean, and you can see them in there. every time I press the button, they cringe. I know they can hear it, but they won't say yes. So then I start saying the words, and it's amazing how they can hear hot dog at, you know, way up at 0, and I'm like, yeah, your kid's fine. I'm like, they're just giving you a hard time, you know. It's probably something else that's, you know, coming out in this hearing loss. And then yeah, and adults do this too. I should not just say it's children. Adults do this as well, and it's so frustrating.
Is that what we call selective hearing?
So that is a good way to think of it. Yes, yes, or bluffing. Yeah, so we see a lot of that. All right, and the other thing is word recognition. So I repeat a list of words, and it's at a certain level to where all those words should be audible to you. So I run through a list of words, and what we're trying to identify is what percentage of those words do you get correct, because that's a reflection of your word understanding in the brain, okay? So we're not just looking at, it's more of your comprehension, so word recognition and at the level of the brain. The higher the score, the better, the clarity and the integrity of your system is better than when that score starts to go down. And there's a lot of things that contribute to that word understanding as far as the integrity of the cochlea, the 8th nerve, and the brain and all of that. So, okay. Whoops. Yes.
Some of our companies that we do testing for, some require from a 500 frequency to an 8K.
Mm-hmm.
Some only require to a 6K. But isn't 8K the standard?
It is. 250 to 8K is standard. So, meaning hertz as far as that goes. So yes, that is standard, but I do see sometimes 500 hertz to 6,000 hertz is more often tested. Why, I'm not exactly sure, but my thought is that they want to test, and would this be, occupation, right? Okay, yes. So with hearing loss, occupational noise exposure, the frequency that's very susceptible to having damage is 4,000 hertz. So they want to do 6,000 hertz to see if it recovers or if it continues to go down for noise exposure claims or things like that. And so that's probably why they do the 6,000. 8,000, yes, is a standard. So I don't know why they're not necessarily doing that. But
well, we test for 8,000 because it's on a machine. We push a button and it does it anyways. But for certain companies, we only report it up to 6.
Right. Yes. And we do some military testing, and they have different requirements as well. So it's very different as far as that goes. So hard to say why they only go up to 6, but that is the standard to go to 8. But I do see that every once in a while, this kind of abbreviated version of test frequencies.
Okay.
So,
I'm sorry.
No, that's fine.
Because I do a lot of hearing.
Oh, okay. Yeah, no, that's great.
So we were using this other software program for recording the results for the hearing. And we recently switched over to a new program. In the old program, the decibel levels went from 0 on up, 10, 15, 20, 40, 65, 75 to the max.
Right.
In the new program, same thing, goes from 0 on up to the max, but it provides a negative.
Yep.
Explain that to me. I don't understand that at all.
Yes. So I wish I could go back. How do I do this? I bet I can go previous. Here we go. Okay, so we've been given this graph. However, hearing goes off the grid this way and off the grid this way. So 0 is this, it's not even really 0. It's kind of this, what do I want to say? It's based on, it'll come to me, this other system. However, we test 0, -5, -10, it goes even higher. Yes, and that's what human hearing does go.
You're guessing that it's coming,
It's crazy because sometimes I'll start at 0 with little kids and they're just like, yes, like it's loud. And so I know that I could go to -10 and they're definitely still going to hear it. But 0 is categorized as normal, so I'll just do kind of screening across the zeros. I know you're in the normal range, we're good to go. So, and that's if and then I'll document that I just did a screening at 0 dB so that they know I wasn't actually finding a threshold. But yes, so hearing does go above that 0 mark, and it also,
So there's actually sound above the 0.
Okay.
yes.
Just like you could see
I thought
better than
0,
2020.
beyond that there was no sound.
Okay.
It is, it's not a, it's just, they've created this graph for us to succinctly explain and measure hearing, but it does go beyond the graph. Hearing tests, I just was at a conference and the patient said that when she started getting her hearing tested, and she's had hearing loss for many, many years, the audiogram when we went to, what was it, 75. Well, her hearing was reaching that and she's going, oh my gosh, what do I do when I'm off the chart? Well, the next couple of years, they redid the audiogram for standard and it went down to 100. She's like, oh, thank goodness. Okay, I still have some hearing. So psychologically, this was like really impactful for this woman. She's like, I'm gonna be off the chart. What do I do? I won't, you can't measure my hearing. And then finally it's like 120 and she was just like, okay, I'm good. And her hearing has really stabled out, but she's got a very significant hearing loss and that was horrible for her. She's like, I'm gonna be off the grid. And so hearing, I mean, what starts to happen is we get that vibration at that very, very high presentation level. So I think that's probably why they keep it there, but yeah, so it can be off the grid.
So, yeah, I think we're off the grid at either 90 or 95, I can't remember. And we do get some patients, we call it a flat line, when they're all zeros. And, we pat them on the back, say, protect your hearing because you got excellent.
Yep.
Stuff like that.
Yeah.
The, I'll take it.
Okay, yep,
Yes.
just yep, let me know when you think of it. Okay, so I'll just kind of breeze through this slide because we already kind of talked about it. I can hear, but I can't understand. There's nothing more frustrating than for folks when they get a hearing aid and they still can't understand, and when they're in noise, it's very challenging. And that's that word recognition test. So I use that percentage in my counseling. Look, you only have 40% word understanding, so even with the best hearing aid on the market, you're not going to do so well because it's the way your brain puts sound together. So you're going to have to use communication strategies. You're still going to have to put in effort. So that's kind of one of those things, and I won't talk about the brain, but it's just there's the auditory region. I was throwing in a slide there, but yes, so it's one of those things that is a lot of counseling because and typically when folks wait too long to get hearing aids, their brain just doesn't